So to recap our mission, we spoke about this last time, and each time we highlight a different sort of area, but really our goal is threefold, which is to provide great information, to fund research, and to advocate and support people living with migraine and headache disease. And we've spoken already about the PBS listings, and last night we spoke about the new medically reviewed articles that have been released. And today we're going to be talking about Shades for Migraine. This was a campaign that originated in the US from some lovely people at Migraine, at the American Migraine, the Association of Migraine Disorders, I should say. And that's a nonprofit. And they came up with this wonderful program that's easy to do. It's simply wearing a pair of sunglasses, taking a photo, and using a hashtag to drive awareness for migraine. And this year, Migraine and Headache was an official partner of the event, and we had some wonderful pamper packs worth over $350 each, with a bunch of goodies involved that just, when you have a migraine attack, we just wanted to make life easier for those individuals. And we had some wonderful partners that donated the pamper pack items, which you can see in the bottom left corner there. So it was a great event. We'll be participating again next year, so keep an eye out for that. We share information via email ahead of that event. I'd also like to thank our sponsors for Migraine and Headache Awareness Week. Without these sponsors, we wouldn't reach nearly as many people. We have hundreds on the call, on the webinar, and thousands who participate over the course of the week. And so special thanks to Hydrolite, Teva, Lilly, the Brain Foundation, Lundbeck, AbbVie, and Pfizer. So you're in the right place if you have headache or migraine. If you're a parent, partner, or caregiver, if you'd like to connect with others like yourself, we have a support group that we host on Facebook. You can look up Migraine and Headache Australia support group and find us there, which is a free group. And and you're also in the right place if you want to ask a question. We'll have dedicated Q&A time about halfway through the session. Now, to introduce our speaker, Dr. Jason Ray. He is a neurologist and a headache fellow at the Alfred and Austin hospitals based in Melbourne. He's the sole headache fellow at the Alfred Health Headache Service. He's got a particular interest in novel therapies for migraine. He recently completed a review on CGRP that was published in the Journal of Neurology, Neurosurgery, and Psychiatry. He's actively involved in headache research and clinical trials. He's passionate about education, and he's undertaking his PhD at Monash University. A very busy individual and a very passionate one for migraine and headache, and we're fortunate to hear from him today. And so with that, we'll commence his presentation.
Good morning. It's a privilege to be invited to speak to you today, and the brief that I've been given is to talk about several primary headaches disorders. My name's Jason. I'm a neurologist and headache subspecialist working at several hospitals in Melbourne in Australia. These are my disclosures. The information in this presentation is meant to be of a general nature. It won't be relevant to everybody, and it should really be discussed in partnership with your healthcare team. Several of the medications that are used for prevention of headache disorders and that we may discuss in Australia, whilst they're supported by evidence, are off-label on the PBS. And again, this needs to be discussed with your treating clinician. And the information in the presentation is referenced, but also represents my own views. I've previously received unrestricted funding or compensation from several pharmaceutical companies with my activities, but none of which should be of relevance to this presentation. By way of overview, I'm going to talk briefly about classification of headache disorders, focusing then particularly on my brief of new daily persistent headache, cluster headache, and migraine, focusing on menstrual migraine and vestibular migraine. In terms of the classification of headache disorders, the way we approach this is through the International Classification of Headache Disorders, which is now in its 3rd edition and gets put out by the International Headache Society. It's useful in that it provides a uniform way of communicating so that when we're discussing things in correspondence between treating clinicians, we know what each other's talking about, and it provides a framework from which to work. But it is by its nature an artificial construct, so the classification isn't perfect and not everyone fits neatly into one of the classifications. Within the classification system, there's a variety of different groups. So there's primary headaches, which conceptually you can think of as the headache itself is the problem. secondary headache disorders where the headache has arisen as a consequence to a second problem or pathology. And then there are neuropathies and facial pains and other types of headaches that don't fit neatly into those groups. So broadly speaking, if you imagine the corollary as dementia is the grouping term in the same way as primary headaches are grouping terms. And then within that, there's individual conditions like Alzheimer's disease or vascular dementias or Lewy body dementias in the same ways. The primary headaches, there are individual conditions, the migraine, cluster headache, and so forth. Now, starting with new daily persistent headache. New daily persistent headache was first described in the literature about 30 years ago, but descriptions of it date back far further, and there are descriptions of a new onset severe day continuous headache that coincided with the Spanish flu, for example. In community settings within Europe, the 1-year prevalence of new daily persistent headache is estimated at 0.03 to 0.1% of the population, so it's a rather uncommon headache subtype. And the pathognomonic presentation is that of a persistent, so a continuous headache that starts on a particular day, so has a clearly remembered day of its onset, and then it unfortunately continues for at least a 3-month period. And the ICHD-3 criteria is just there for your reference on the right of the screen. In terms of possible causes of new daily persistent headache, this is unfortunately an area where we don't have a lot of information so far. It's likely that new daily persistent headaches are a net result, so they're a heterogeneous group of conditions that have arisen for different reasons in different people. There's a lot of evidence that in some people there's a potential infectious trigger. Let's say a significant proportion of patients will identify a flu-like illness at the onset of their headaches, and there's been a little bit of research in this regard, and so there's higher rates of the Epstein-Barr virus that's been reported in new daily persistent headaches than in controls, and there's been other reported viral and bacterial infections that have been reported as potential triggers. There's some evidence as well that there might be a possible subicogenic triggers. So in some case series, patients who didn't have infectious triggers when they were investigated for joint hypermobility were found to have higher mobility on a Bayesian score, which is a clinical scoring of joint hypermobility. And in another study, there was found that 10% of patients who otherwise hadn't found a trigger had an onset following intubation, which involves a little bit of neck manipulation. So there's potential for that as a potential trigger. Whilst these give us some clues as to what may have happened to begin the process, there really needs to be a lot more research in this area, and it's an area of ongoing research interest for a lot of groups around the world. Whilst these triggers are true and present for individual patients, when we consider the other side of the coin, the number of people who each year get an infectious trigger, the number of people each year who undergo intubation and who don't have onset of headaches, there's obviously more to this equation that we don't yet understand. In terms of diagnosis, so the diagnosis is very much made in consultation with your clinician, and it's made on the basis of the clinical features. So a typical history with an unremarkable examination and imaging findings is supportive. Often with new daily persistent headaches, just because of that sudden onset, an MRI venogram is often undertaken just to exclude potential mimics for new daily persistent headache. And unfortunately, whilst I was asked to speak briefly about the treatments, there's really a lack of randomized trials and really high quality evidence to guide the management in this case. So there's no particular best practice that is true for every person. And so the majority of headache specialists will discuss treating the predominant headache phenotype. So if the patient has suffers from a more migrainous phenotype, then they will often try some medications which are more indicated in the case of migraine. And in case of it, if it's tension type headache phenotype, then we'll try that in the first instance. Noting again that whilst these medications are supported by some evidence, they're often used off-label In terms of prognosis, this is, again, an area which needs some further research. So in the earlier studies, so going back into kind of 2004 and prior, the studies which suggested the prognosis from new daily persistent headache was that between half and 3/4 of patients had a remission in their disease and became headache-free after a 2-year period. In clinical practice, this seems to vary, and it very much varies depending on the group that we study. So, for example, there's one large study by Robbins who took a group which we see more in the tertiary setting in headache clinics, that people who've had it for a greater period of time, that only 15% of people report complete or partial remission. So that's no more than 4 days a month of headache. And it took about 21 months to get there, with the median first remission time happening only after 6 months. So there's quite a spectrum, and it's probably, as we get more information in this area, to really get some more granular detail, that there's probably slightly different groups that we're talking about here when we see such disparate prognosis. Moving on, the second condition which I was asked to discuss briefly was cluster headache. Now, cluster headache is, again, a rare subtype of headache disorders, but unfortunately a very, very disabling one. It has a pooled lifetime prevalence, so across the course of the life, of 0.1%. So it's, again, another rare headache disorder. And in contrast to migraine, it has a male predominance. There's also a bit of a genetic component, with first-degree relatives of somebody who suffers from cluster headache having a slightly higher risk of developing the disease. In contrast to migraine, which, if we went for the typical phenotype, somebody who wanted to lie down in a dark room because movement makes the pain worse and light is bothering us, the picture for cluster headache is slightly different. So it's, people have a sense of internal agitation, or restlessness. So you often want to get up and pace and move throughout a room. You have strictly side-locked pain. So during a cluster, it stays on the one side and it's very anterior. So it sits over the temple or behind the eye. And you can get what's called cranial autonomic symptoms, which we call the 3 A's. So cranial autonomic symptoms happen on the same side as the pain, and the tearing of the eye or discharge of the nose, flushing of the face, also such symptoms. And the ICHD-3 criteria is, again, there on the right. In terms of causes of cluster headache, this is, again, as with all the headache disorders, still incompletely understood, unfortunately. But we know that there are some key regions of the brain that are involved and activated in this setting. So there's the trigeminovascular symptom, which is what gives us the perception of the pain. And really, it's a unilateral activation, so we only get the pain on the one side. The parasympathetic system gets activated because of some crossed branches in the particular area of the brain, which allows both systems to activate, and that gives us the autonomic symptoms of tearing and redness and discharge from the eye, as that we talked about. And then because the hypothalamus, which is an area deep in the brain, gets activated, people will often have a bit of a circadian rhythm to the pain, so that particularly in cluster headache, you'll often find that, unfortunately, the pain comes on 10, 11 o'clock at night in the evening, and it can have a seasonal variation too, particularly in the lead up to spring, as we're coming to now, that episodic cluster headache can be more likely to have an attack. There are three prongs of managing cluster headache from our perspective. So we want an acute treatment because we want to stop the pain as quickly as possible. It's absolutely devastating pain. We want to start a bridging therapy, so we don't want the pain to come back the next day and the day after. So we want something that we can put in place quickly to try and get somebody out of the current cluster. And then we want to bridge that to a longer-term preventative strategy to try and reduce future bouts. Somebody requires it. The management in this setting, so in terms of the particularly effective things, so from an acute treatment perspective, so either a quick-acting triptan, which often will favour a subcutaneous, so an injection underneath the skin, or an intranasal version of sumatriptan, just because it acts that much quicker, or high flow oxygen. And that's often will generally require a prescription, and obviously there's some safety issues with both of those. That you can't be an active smoker or have an active smoker in the house in the case of oxygen, or ischemic heart disease, these are previous heart attacks in the case of the triptans, in order to make those safe medications. Starting a bridging treatment, there's a few different options here, but often the ones which get used most often a course of oral steroids such as prednisolone, or a greater occipital nerve block, which is a particular type of regional nerve block which your neurologist or a trained clinician can provide just underneath the skin of the back of the head, which can provide some immediate relief and continue to have some effect for up to a few months. In terms of preventative treatments, the first-line therapy is generally verapamil, but there are several other treatments for those that either don't tolerate or don't find efficacy with verapamil, which have varying grades of evidence. Lastly, I was asked to speak briefly about migraine, but focusing particularly on menstrual and vestibular subtypes of migraine. Again, by way of background, migraine, as unfortunately as a very disabling condition and a very common condition, is responsible for the second leading cause of years lived with disability worldwide. Depending on the study, internationally, it's estimated to affect between 1 in 5 and 1 in 7 people, but we don't have good evidence for what is happening in Australia in the epidemiology of the disease. It's more common in females, which comes from some relationship with ovarian hormones, and up to 30% of people who have migraine can experience a migraine aura. Talk a little bit about the vestibular symptoms in that context. And again, the ICHD-3 criteria is just sitting there on the right for your interest. As you talked about, there's a real need for a better understanding of how migraine is affecting people in Australia and how many people in Australia are being affected. This is really a first step which Australia is really behind the 8 ball on, that we just don't even have good data of how many people are unfortunately affected. And it's really needed so that we can understand the breadth of the problem, and so that we can lobby to try and help bring migraine into the minds of decision makers and policy makers throughout the healthcare industry and within government. One of my colleagues, Dr. Foster, is doing a pilot study here with this very significant issue in mind, and she's partnered with a great deal of organisations from their perspective to try and help answer this question, including this one. And this is really just a reminder that to keep an eye out for your newsletters in the coming months, that come November, you'll be putting out a invitation to participate in this study through the newsletter, to answer questionnaire and really to try and help shine a light on migraine for people. So wonderful work which we're hoping to support. So speaking briefly on menstrual migraine, we can subtype this into menstrually related migraine, which is where people will have a worsening of their migraines between days -2 and day 3 of their menstrual cycle, but will continue to have migraines at other times of the month, and pure menstrual migraine, which is a terrible term, but is where somebody solely gets migraines in association with their menstrual cycle. In terms of the epidemiology of menstrual migraine, it really speaks again to the need for further significant input from funding organisations, from interest from researchers, to try and help give us better data. Because even when it comes to menstrual migraine, there isn't a great deal of high quality evidence from this perspective. So the estimated prevalence of menstrual migraine amongst patients who have migraine is somewhere between 4% and 80%. But on the existing studies, it's just such heterogeneity that we don't have a good figure from that perspective. Again, this is unfortunately the case for a lot of the neurology. The causes aren't completely understood still, but there's good evidence that it relates to estrogen withdrawal. This dates from early studies where if somebody was having a withdrawal of estrogen, which happens towards the end of the luteal phase in a woman's cycle, and then we bridge that period with some estrogen, then we'll be able to delay a migraine. And it's not until you withdraw the estrogen a little bit later so that you will then go on to have your migraine. So estrogen seems to be quite linked to this process. And there's certainly a lot of reasons why this may be the case from a biological level. So estrogen hormones act in the central nervous system, so in the brain itself, as well as throughout the body in general, and they alter the excitability of several systems in the pain processing networks in the brain, as well as the tone of some of our opioid receptors in the brain. So it makes it easier for a migraine to occur, but also often, unfortunately, the migraine that does occur around the time of the menstrual cycle is actually, here for several reasons, a more painful migraine, and also a slightly more difficult one to control just from the way that it's modulating the pain systems in the brain. In terms of trying to manage menstrual migraine in particular, we start with all of the general approaches that we have for migraines, and we're addressing lifestyle factors as best we can, having acute abortive therapies that are effective, having preventative treatments for the migraine that are effective if they're indicated. But there's other particular options which we can also consider when it comes to menstrual migraine. So if it's very infrequent, then we can just focus particularly on the abortive therapy side. But if it's either of a long duration or we can't control the migraine, so we can't abort the migraine very well with acute therapy, then it's worth considering preventative strategies as well. If you have a predictable, regular cycle, then that gives us the option for preempting the migraine. So we know that, for example, that if it's going to come a day or so before your period, and you are on a 28-day cycle, for example, then we could start a short-term preventative strategy a day or two before we expect the migraine, in the hope of either lessening that migraine or avoiding it entirely. And there's a few different short-term strategies that can be employed, including some of the longer-acting triptans, such as naratriptan, or a longer-acting anti-inflammatory medication, such as naproxen, obviously in the appropriate patient. There's a caution, obviously, when it comes to the triptans, and that in general, with migraine, we can't exceed more than 10 days a month of use of the triptans in order to avoid the risk of medication overuse headaches. And so if we're using 5 days of our triptans around the time of the period, then that gives us fewer days in the rest of the month that we can take the triptan for. And so that's obviously a consideration we need to take into account. Other things just in passing in terms of management, obviously, if we're worried that the withdrawal of estrogen has implicated in the setting of menstrual migraine, the question becomes, is there anything that we can do to try and help support things from that perspective? And there certainly are some hormonal based treatments which can be helpful as well. So if you're somebody who is otherwise on the combined oral contraceptive pill or haven't wish to be on it, obviously you need to consider the overall risk of thromboembolism and so developing a clot, which is increased in patients with migraine with auras. That's of relevance to you. And your overall risk in general, if you're somebody who smokes, obviously that increases the risk of thromboembolism, and we'd recommend people stopping smoking. If, however, the combined oral contraceptive pill is an appropriate choice, then sometimes continuous cycling, so avoiding the sugar pills, can improve symptoms because we're avoiding that withdrawal of estrogen that occurs. On the other end of the spectrum, as people enter the stage of their life with menopause, the majority of people who have hormone replacement therapy for another reason will also report an improvement in their migraines if they were having a menstrually related migraine prior to the onset of menopause. But obviously this is something which you'd need to consider in the context of your general health, and it is not necessarily a recommendation for everybody. Finally, and very briefly, on vestibular migraine. So the prevalence of vestibular migraine amongst patients who have migraine with aura is not very well described. The estimates vary greatly. Some studies that will say 3%, some that will say 10%, and some even higher. Vestibular migraine is where you're having vestibular symptoms that are moderate or severe intensity, so they really can be quite impactful on your life in relation to your migraine headaches. And these symptoms can be relatively short. They can last as little as 5 minutes. But in contrast with a lot of other migraine or symptoms, the duration of vestibular symptoms in vestibular migraine can be quite long as well. So they can last up to 3 days, and some patients will obviously have longer symptoms as well by the ICHD-3 criteria, up to 3 days. And there's a lot of different descriptions of vertigo, vestibular symptoms that people can have. So vertigo, which is that's the medical term for the sense of movement, which is not a true sense of movement. So it's not a cause, it's a description of a symptom, can present in several different ways. So you can have spontaneous vertigo, where you have internal vertigo, so the false sense that you yourself is moving, or external vertigo, which is the false sensation that something in your surrounding environment is moving, or the entire environment is spinning or flowing. This can either come on spontaneously, or you can have positional vertigo, so it comes on only after a change in head position. Visually induced vertigo, which is triggered by a moving stimulus. So often, unfortunately, for patients who suffer from this, it's things that we can't avoid too easily, like the movement of a car. And head motion induced vertigo, which occurs, the term describes with head motion. The management of vestibular migraine is again an area of ongoing interest, and it's actually something which the fellow in our institution at the Alfred is looking at the moment. And particularly their research interest is the impact of botulinum toxin and the new CGRP monoclonal antibodies on vestibular migraine. Briefly though, the individual attacks of vertigo where we want to treat much in the same way as with any acute migraine treatment, but making sure that we have some antiemetic and potentially some antivertiginous medications on board as well if we need. Unfortunately, whilst the general acute migraine treatments, so the anti-inflammatories and the triptans, can be still very effective for the headache pain itself, they're not as likely, they still may, but they're not as likely to have an effect on the duration of vertigo itself, per se. So often people are still quite disabled by the vertigo, even if we are able to abort the pain. In terms of preventative management, so the non-pharmacological measures are very important in vestibular migraine. So both in terms of trigger avoidance, if we find something which is particularly triggering of the vertigo, to try and adjust this, that also working with a specialized physiotherapist or physiotherapist with expertise in this area, you can really have some dramatic improvements. So there's one study that found that 40% of people who had a significant improvement in their dizziness disability with the non-pharmacological measures in vestibular rehabilitation. And then because we can't stop the vertigo with an acute agent all of the time, we come back to the underlying principle. If we want to try and reduce the number of migraines as much as possible, and so pharmacological prophylaxis, preventative treatments are certainly indicated in if you're having frequent attacks or disabling attacks that are difficult to treat, and they're worth discussing with your treating clinician. But unfortunately, there's no particular head-to-head study yet specifically for vestibular migraine that I can recommend to you one treatment over another in all patients. That's all of the slides that I had. I'm very happy to take any questions as best as I can. Otherwise, thank you very much for the opportunity to speak to you and to try and raise the profile of headache disorders and treatment for people in Australia. Thank you.
We've got Dr. Ray with us live here to answer your questions. And I can see that a bunch of questions have come in. I just want to thank Dr. Ray for that fantastic presentation. It's very difficult covering 4 different types of headache or migraine, and he did a great job. And I know there's going to be a couple of questions as well going back to each of those. So we'll jump in to hormonal migraine. And Janique asks if HRT is helpful in the treatment or prevention of hormonal migraine.
So it certainly can be. So part of the reason that we think that hormone or menstrually-related migraine comes about is due to the withdrawal of estrogen, which often happens at the end of the luteal phase. So anecdotally, that was been supported by a few different studies. The role of hormonal replacement therapy varies with based on somebody's individual experience and their own medical history, but the majority of people around the will see a benefit from hormone replacement therapy in terms of the frequency of their migraines. At least that's been the experience in observational studies. Some people can have a worsening of their migraines as well. So it's generally not something which we will often go to in the first line as a preventative strategy. But if there's another reason or if there's another role for hormone replacement therapy, then it's something which we'll discuss in consultation with the general practitioner specialist or gynecologist who's also involved.
Yenny wanted to know if there's a natural option to actually addressing hormonal migraine.
That's a really good question. So in general, in the management of migraines, we kind of split everything up into 3 broad categories. So there's acute therapies, which can be used to help stop an attack. There's preventative therapies, which we can try to help reduce the frequency of attacks. And then there's lifestyle factors, which make it more or less likely to have an attack at an individual time. So when we talk about the more natural side of the therapies, so the non-pharmacological therapies, there are certainly things in that first and third category which can really be particularly helpful. So in the case of acute therapy, so stopping an attack, there's a few different things that aren't medications that have been shown to be helpful. So rest, obviously, some people found that meditation and other those sorts of therapies can be helpful. And in ice packs, have actually somebody managed to do a randomized trial of using ice packs in acute migraine, so that these can all be natural strategies. And then in terms of the lifestyle factors, particularly around the time of your period, being a little bit more aware of your other migraine triggers and trying to have as many things working for you rather than against you at those times are probably the best natural strategies. There's also a couple of migraine supplements which have a bit of evidence, so magnesium, riboflavin, and CoQ10, which can all be helpful. So they're not specifically menstrually related, but they are natural things that can be helpful in migraine in general.
I think that makes a lot of sense as well, particularly when you sort of know when your fluctuations are going to be occurring, and if you know for that week that you can sort of take it a little bit easier, make sure you're sleeping well, make sure you're not eating as much processed food and taking care of yourself. Just generally, you have the best chance of having relatively a less painful sort of time during that phase from a natural
Absolutely.
perspective. Yeah,
and it's true for other triggers as well. So if you're going through if you're going to go through a particularly stressful period of time with work or with exams for university, or you're traveling and your sleep's going to be disrupted, not adding in on that and adding in other things that are going to be that you've recognized as triggers is certainly helpful.
Fantastic. Jenny had a comment saying that her GP suggested that she have a baby and see if that helps with her menstrual migraine. We had a few people on the webinar last night who actually said that their migraines got a lot better during pregnancy. I don't know whether it stayed better after pregnancy, but apparently it can help. But it's not, I'd say, the first reason to have a child.
Look, we would probably step back from recommending that as a prophylactic technique in any neurological disorder, but it is something which can sometimes be helpful. So not just in menstrually-related migraine, but in migraine in general, the majority of people after the first trimester who suffer from migraine will see a reduction in the severity or frequency of their migraines. That's not true for everyone. So it doesn't help delineate in terms of the cause, because it affects all migraine. What we tend to see, at least in our experience, is that whilst we see people who have a benefit in terms of their headache frequency particularly through the second and third trimesters of pregnancy, whatever the frequency tended to be prior to going into the pregnancy, people tend to revert back to within a few months of postpartum. Part of that's due to the ovarian hormones all return back to doing what they're normally doing, but also because we're under a great deal of stress at that time, that sleep is disrupted. There's a number of other factors that will go in at that point to unfortunately compound the disease.
Carly asked a question about the changes that can occur in migraine, particularly from a frequency of say once a month to sort of once a week. Is that something that we can just sort of ignore and perhaps sort of tolerate, or should we be doing something if that's occurring?
So whenever we're meeting somebody who has migraine or a headache disorder in general, the first question from us as a clinician is, what are we dealing with? So, if somebody's presenting as saying they have got migraine, we want to have enough, explore the history enough that we're comfortable that that's in fact the diagnosis, that it's not one of the rarer subtypes of headaches, but also that it's not something else as a secondary headache disorder. So where there's something other disease at play, which is mimicking the migraine. In general, if you're having a real increase in the frequency of your headaches, and that's something we'd want to explore further to make sure that that's not the case. That being said, there are very much some natural fluctuations in migraine. So it's an individual decision as to whether or not that's something which needs further investigation, or whether it's just the natural variation of migraine. And if there is an increase in frequency, what the best way is of addressing it. So by the time people are having 2 or 4 migraines a month, we may have more of a discussion about trying to reduce the frequency of those migraines back down so it limits the disability and the impact that it has on your life, but also to reduce the impact of any other complicating disease like medication overuse headache, which arises when you're unfortunately needing to take too much painkillers too often because of the frequency of your headaches.
Jenny had a question about how to convince her GP that her cluster headache, her headaches are real. How would you advise patients to speak to GPs who are skeptical? That's
a real challenge question, because we really do want to work in partnership with everybody. If at any stage, I suppose, if you in a discussion with a healthcare practitioner and you're not on the same wavelength, that that you're presenting to them with any issue which you feel is being repeatedly dismissed or not appreciated, getting a second opinion can sometimes be helpful. So either saying, look, we respect the experience of the practitioners, but much like with a mechanic, much like with a physiotherapist, much like anyone, if you don't have that therapeutic relationship, seeing whether there's somebody else who can help, or asking your GP to say, can you refer me on to a neurologist? Can we get another opinion on this? If not from a GP specialist, then from a neurology specialist.
Crystal had a question. She's been treated for migraine with topiramate and standard migraine, but what you described about cluster headaches sounds very familiar. They tend to get worse during spring and summer. She has pain on one eye, behind the eye. She's got the tearing, flushing, feeling like moving about rather than lying down. But she has light sensitivity. Is this cluster, or does this sound like cluster or migraine? And is it due to seasonal factors, or is it triggers for migraine that sort of are causing it?
Yeah. It's a really good question. Unfortunately, not one I can address directly for you, Crystal, in terms of your particular circumstance. So there's you certainly can get sensitivity to the light in both cluster headache and migraine, and you can get some seasonal variation in migraine. I think I saw a chat message go through bemoaning living in Melbourne and the weather is triggering migraines, and certainly there's something about that that we really haven't pinned down. If it's sounding like cluster, then getting a second opinion, getting a neurologist just to have a look and see what they think as well could be beneficial, because it is something which, unfortunately, despite the severity of the condition, despite how much it impacts people, there are real delays in the recognition and diagnosis of cluster headache. It varies throughout the world, but it can be as much to 8 years on average before somebody sits back and sits there and says, actually, I think this is cluster. On the other side of the coin, when we look at all coming patients who have that, side-locked, horrible headache, cluster headache isn't responsible for all of them. So about 10% of people with that story actually do have migraines, and migraine can present that way too. So it's really something which we'd need to go into great depth in a consult to give a good answer to.
Susie asked, with cluster headaches, do they resolve or do they keep coming back episodically?
Different pattern in different people. So some people who have cluster headache will have a bout of a cluster headache 1 year, perhaps another year, and then they won't be troubled with it again. There's other people who will continue to have it seasonally throughout their lives often. And so they're obviously very different strategies that we bring to managing those two people. And then there's a third group of people who either begin or become chronic cluster headache, where you lose that seasonal variation and you'll just suffer with the pain throughout the year, which is horrible.
Suzanne says that she suffers from tension headaches every day and doesn't know which way to turn anymore. She's had tests for migraine, but nothing seems to be working.
It sounds like a terrible position to be in. I'm very sorry, Suzanne. And unfortunately, when we talk about managing tension headache, it hasn't had the same number of trials, the same number of drugs and therapies tried in it in comparison to migraine. So there's less things that we can sit there and say, this is definitely the right choice or the next choice. There is always further things that can be tried, though. So I'd encourage you to see your GP, get a referral to a neurologist. If your neurologist has thrown up their hands and said there's nothing to be done, get a referral to a second neurologist and see what else we can do. There's generally other things that can generally be tried, but it's an individual discussion.
Moving to new daily persistent headache, Diane said that, I asked a question about whether new daily persistent headache could be caused by sleep apnea. Can you speak about sleep disorders as well in general with in relation to these headaches?
Yeah. So new daily persistent headache itself hasn't, there's no evidence that I'm aware of that it has arisen as a cause of sleep apnea. So sleep apnea can present in, from a headache perspective, in a very specific way, that people tend to wake with early morning headaches, which then improve throughout the day, and often within an hour or so of waking tends to be the kind of the quintessential headache which you get with sleep apnea, and that's related to the sleep disordered breathing and the rise in the carbon dioxide in the blood, which can cause some secondary changes in the brain. So it can be a clue in those settings that if you're having non-restful sleep, if you're feeling tired all of the time and you're having those sorts of early morning headaches, that's a trigger that we'd want to be going into evaluating that further. In terms of sleep disorders in general in headache, so there's a little bit of a two-way relationship in that having the sleep disorder can be a trigger for your primary headache disorder, like such as migraine or such as new daily persistent headache, because sleep is really so important as a lifestyle factor that to address. But also there seems to be an increased prevalence of sleep disorders in general in people who suffer from headache disorders. And it's something which is an ongoing area of research at the moment, is to really trying to explore that two-way relationship and how we can best intervene on it. But the Sleep Foundation in Australia has some excellent resources in terms of sleep hygiene and different resources from that perspective. So if it's something which is of relevance to you, I'd really encourage you to explore that and discuss it with your general practitioner.
Sharon wanted to know whether new daily persistent headache is often confused with migraine.
Certainly, new daily persistent headache can be confused with migraine, and it's really quite difficult sometimes to tell them apart when new daily persistent headache was first added into the ICHD-3, so into that classification system, which a lot of us practitioners rely on. It didn't recognize at all that people could have migrainous symptoms and have new daily persistent headache. And it wasn't until this back in 2004 with the last generation of it, and it really wasn't until the current iteration, and after a lot of groups were publishing secondary and saying, well, actually, 2/3 of people with new daily persistent headache have headaches that sound migrainous, that it was really recognized and something which was explored further. So it's an evolving area in this front, and there's only now really some groups that are really starting to get into new daily persistent headache on a research level and trying to pull apart why it's happening, what treatments are the best for it, that we're actually getting a little bit further. But it certainly is, unfortunately, new daily persistent headache can be confused for migraine, and migraine can and other things can be confused when it is in fact migraine.
And I think that answers the question from Ali, who was asking whether new daily persistent headache can have symptoms of migraine. And that's a clear yes.
Yes.
A question from Singrid was whether new daily persistent headache can be triggered or initiated by COVID or a COVID vaccine. Have you seen any case studies or examples of that?
Yeah, so I mean, historically, we've seen cases of new daily persistent headache with different viral infections that have come through, and certainly COVID was no exception from that perspective, that there was a subgroup of people who had a triggering of new daily persistent headache following an acute infection of coronavirus. It's something which I think we're only just starting to really get to in terms of the research around this particular iteration with the pandemic. A lot of the early research was focused on the outcomes of people with coronavirus, and from a mortality perspective, and from the brass knuckles of the pandemic. And it's really only coming on in the latter part of the pandemic, once the health systems were a little bit more organized, that we're starting to really explore the iterations of the other complications of COVID, both the headache disorders and the other medical complications which seem to be arising from it.
Is there a first-line treatment that you use for new daily persistent headache that you find helps a significant portion of your patients, or is it really just hugely independent, like variable on the individual?
It's hugely variable on the individual. So the general approach around headache neurologists is to try and treat the phenotype of the headache. So if somebody has more of a migrainous headache, we'll favor the medications that have more of an evidence around in migraine. If it has more of a tension type headache, then favoring some of the medications which are more likely to be helpful for tension type headache. But unfortunately, it is an individual discussion, both on the phenotype of the headache, but also what other issues a patient may have in terms of other comorbidities, and also what they've tried in the past. We don't want to revisit things that haven't been helpful.
Great. Yeah. And that was a question from Caroline. Monica asked about, having a sudden onset being a characteristic of new daily persistent headache. Could a CSF leak be a cause? And can you tell us what a CSF leak is?
So a CSF leak is, so the brain and the spinal cord exists in our bodies, in essentially the box of the skull and the spinal column, and it's held in place in part by the production of clear fluid around it called cerebrospinal fluid. A CSF leak can occur either spontaneously or in the setting of trauma. And that occurs when that occurs, the CSF, which usually is made and absorbed within that box, it breaks out of the box, and so it leaks into a different part of the body, and certainly can be responsible for different types of headache disorders. So the specific term for as a headache disorder for that is spontaneous intracranial hypotension, where you have a CSF leak and a headache which arises from it. So I think that in answer to her question, there's not a lot of evidence to suggest that of CSF leaks as a cause for new daily persistent headache, because where we've identified the CSF leak, they get classified down in that direction. But I think that that's going to be an area which we'll have an evolving knowledge of in the next few years, because we've started to recognize that intubation, for example, is in some people a trigger, and so I wouldn't be surprised if there was more of a story from that perspective, that in the act of the intubation or in the act of something else, that something has happened in that case, and it may well have been a CSF leak. We don't know.
Philip had a question about medication overuse headaches. I know this wasn't one of the types that you covered, but it's an important question. And he wanted to know if you could comment on sort of the characteristics and symptoms of medication overuse and how it sort of is differentiated from chronic migraine.
It's a really good question and a really challenging one. So for me, myself, I guess when we're talking to people about medication overuse headaches, there's often two different things which come up. So the people who recognize that they have a kind of a rebound headache in the setting of an acute analgesic use. So they take an analgesic and they start to get the headache the next day. And in that setting, it's quite easy to have that discussion about medication overuse headaches. But for the majority of people, medication overuse headache isn't so much the rebound headache, which has a different characteristic to the migraine. It's a condition which arises where because we're using the painkiller more often than is preferred, we cause a few different changes in the pain networks and the pain circuits of the brain themselves. So we cause a little bit of neuroinflammation, which is part of what triggers a migraine. We cause some sensitization and some change in the tone of those pain receptors. And we make it to a point where it's a bit easier for the brain to trigger off the next headache. And so the phenotype of the headache doesn't actually change, but the part of what's driving the headaches at that point becomes the medication overuse, in the same way as other things can trigger the migraines as well. So it's rare that it's the sole trigger and it's the sole issue, but it's certainly become something at that point which is working against us rather than for us. And so traditionally we try and help reduce down the level of medication overuse in order to allow people to take the medication, take it for when they need for the headache, but often that requires addressing the severity and the frequency of the headaches in order to give people room to do that. So it's unfortunately a little bit of a process from that perspective.
Jen had a question about hemiplegic migraines, the causes and treatment. And she said that apart from her initial episode that took her to hospital, she's only been treated by her GP, not a neurologist. Should she see a neurologist as they are increasing in frequency?
So in terms of the whether you should see another practitioner, I guess it really depends on how you're going with your GP specialist and both your and their comfort. If there are GP experts who are absolutely fantastic and engaged in headache disorders, and if you're getting a good outcome with them, there's no need to see a neurologist for in particular. Certainly there's not enough neurologists to see everyone, unfortunately. There's, in terms of what causes familial hemiplegic migraine, so hemiplegic migraine it's a in itself very rare migraine disorder, which is recognized in about 1 in 100,000 people in the European studies. The cause for that are recognized so far are some specific gene mutations which change the change the way. Sorry, let me rephrase that. I won't get into the specific pathophysiology of it because it becomes very complicated very quickly, but they change some of the ways that some of the channels work in the brain and allow you to trigger off a migraine, but have a migraine specifically with weakness down one side or both sides of the body and hemiplegia. That in itself has some, where you've got that gene mutation where you have those attacks, there are some specific treatments which may be more helpful. There's also, separate to familial hemiplegic migraine, the more common version of migraine with aura, where you can have motor symptoms as part of your aura. And so that's to be differentiated a little bit because the treatments are a bit different for migraine with aura compared to the familial hemiplegic migraines.
Last question about relating somewhat to genes, but a simpler question is, are migraines hereditary? Joe's interested. She said that most of her family suffer, including her 10-year-old grandson. This was also asked by Julian Russell.
Yeah, so there's migraine being as common as it is a hereditary disorder. So it's something which you're more likely to see in first and second order relatives than the general population would suggest. In terms of what the gene is for migraine, so despite the prevalence of it, despite the number of times we see it running in families, we don't have a lot of single genes that are responsible. So it's what we describe as a polygenic disorder from that perspective, that it's the net result of a lot of different things coming together that causes that frequency of migraine and the fact that it runs across family, as opposed to just a single gene that appears in the same way that you may see the BRCA gene in breast cancer that conveys that family risk.
Excellent. Well, Dr. Ray, thank you so much, and we appreciate your generosity in sharing your expertise and your time with us today. It was a wonderful presentation, and I know people really got a lot out of the Q&A as well. Later tonight at 7:30, we have Dr. Bronwyn Jenkins talking about some research that we did within our own community, within Migraine and Headache Australia. And 600 of you responded to a survey that was only done a few months ago. So we're going to be taking the pulse of the community, and there'll be a lot of interesting findings with that. So don't miss out on that session. And we've also got a session on Thursday coming up as well. So stay tuned, and hopefully we'll see you all again very soon. Thank you, Dr. Ray.
Thanks for having me.